Well, hi everybody. Welcome to Ada County Medical Society's Let's Chat About Telemedicine webinar. I'm the host, Stephen Reams, the director here, and I do appreciate you all taking time out of, I know, your busy schedules to learn more about this. There's no doubt that we have had a seismic shift over the last month in the way that medicine is going to be affected, not just by COVID-19, but all of the other related impacts because of that. I pulled up a few pieces of research I was able to find. Roth and Sullivan consultants said that March telemedicine visits surged 50% in March, and that general medical care telemedicine visits might surge to 200 million this year, and that's just general medical care, possibly telehealth visits up to 1 billion. 3/4 of surveyed patients said they would consider using a telehealth service if they felt they had COVID-19 symptoms. And we know that that's a big change from in the past when only 20% of people thought of or had tried a telehealth visit, and now 2/3 of them say that they may be willing to try that in the future. So we're probably not going to go back to the old normal. We're going to have a new normal when this crisis subsides, and telehealth is certain to play a much larger role in the delivery of healthcare. So beyond the regulatory, coding, and reimbursement questions, which I'll talk about in a little bit, how those are going to be covered, the real issue is how do you actually make a telehealth, telemedicine visit effective as a physician, as a provider? And so we know that 40% in the survey that was just cited, 40% of patients were concerned about the ability to get proper treatment or a diagnosis in a virtual setting. So today we're really excited to be able to have Dr. Sarai Ambert-Pompey from the Boise VA Medical Center share. She's an internal medicine physician who's been conducting teleprimary care for the Vision 20 Northwest VA for the past 5 years. She also trains IM residents in telemedicine and has developed a telepreceptoring program. She received her MD at Ponce Health Sciences University in Puerto Rico and completed her residency through the University of Washington Boise Internal Medicine Residency Program. Also completed a neuro-oncology fellowship at OHSU. We had planned to have Dr. Camille Lacroix, who's a local psychiatrist, with us today. Unfortunately, she had to attend some patients in her clinic and won't be joining us. But for those of you who are in mental health, she wanted you to know she remains a resource in this realm if you have questions. So before we go to Dr. Ambert-Pompey to start her presentation, I wanted just a couple of explanatory slides. First of all, she has no disclosures or financial conflict interest disclosures to make. And what we're not going to cover today is these topics. In fact, next week, Idaho Medical Association already had planned on April 22nd to have their regular Changes and Challenges education series. IMA reimbursement specialist Pam Fisher will cover ICD-10 diagnosis codes and guidance, management consultation modifiers, all of those really fun topics. She's going to cover those at 12:15 next Wednesday. And you can register if you're an IMA member for that at idmed.org. That training is focused mostly on coding and billing and other things that have come up in the past quarter. What we are going to focus on today is our learning objectives. And so we're going to look at how to prepare for a telemedicine visit, how to behave professionally and engage the patient and the caregiver during the visit. And at the end, we will have the opportunity for you to ask some questions. And the way that I want to handle that is to have you put any questions and answers or contributions you might want to make during that time in the chat box. And you can see on the screen here, if you pull up the chat box, you can do that by going down to the More button and click Chat. And in fact, what I want to do, because this is recommended by our presenter, is to go through kind of a brief tour of Zoom to help with this presentation, because as you all get into telemedicine and exploring the functionality of your software, I want you to know that you have permission to tinker and to change some things on your end so that you feel really comfortable with the software that you may be using in the future. Of course, not all the features that are here are going to be in your video conference software, even depending on what device you're using. If you're using a phone or an iPad versus a laptop or a computer, it's going to be different. But so the first thing you can do is look down at the chat button function. And if you all just want to send a chat to everybody, let everyone know that you're here today. That way we know how to use that at the right time. That would be great. Another thing that may be useful for you to know is that there's different views of the speaker as we present. You can view the speaker view where it highlights the person, spotlights them. You can pin them or spotlight the person, whoever is speaking, or you can even view the screen in gallery view, allowing you to see all the participants, and who is being presenting is going to light up in yellow there based on their speaking. And I know that probably a lot of you have figured this out by now, but for some people this still may be a new technology and you're still getting used to it. Another thing to know is that as I'm sharing my screen with my PowerPoint, if you ever wanted to share a screen with a patient, you could do that. You could share an update web page or walk them through maybe a demonstration. And Dr. Ambert-Pompey will talk about that a little bit. And you can see, you can choose side-by-side mode, and I'm hoping that you'll do that today so you can see both our speaker as well as the material that she is presenting. So with that, I am going to turn this meeting over to Dr. Ambert-Pompey, and she's going to take control of the meeting from here. So welcome, Dr. Ambert-Pompey. We're glad that you are with us, and you are ready to take it away. And I'm not hearing her, so let's unmute her.
Unmute now.
There you are.
All right. Thank you for having me, and I'm really excited to be part of this today. Telehealth, it's a really broad term, and it's not really new. The old stereotypical take an aspirin and call me in the morning that has been shown in many movies is definitely not new. Telepsychiatry has been doing it since the 50s. NASA has been doing it, and several other military services. So this is definitely not new. There are different kinds. When the phrase synchronous care is used, it means real time, like we're doing right now. This is synchronous. But some people are going to watch the video that's recorded later, and that's going to be asynchronous. So that's a good distinction to know. So what we do as physicians providing care, we do telemedicine. And the big umbrella term for telehealth is any telecommunication device and healthcare, which can be healthcare education, healthcare coaching, care management, self-management, diagnosis, consultation. Is very broad. And that's the definition that was done by the Idaho Board of Medicine back in 2014. Telemedicine itself is medical information exchange from one site to another via electronic communication to improve a patient's health status. And again, that's the definition that was used in the state. Each state, and I will say, because I do care to several states, have their own definitions, and you can look them up, and I'll show you a website where you can do that. Idaho passed the Idaho Telehealth Access Act back in 2015, which was known as the Year of Telemedicine. And in that legislature, they made some very important points. The patient-provider relationship can be established without an in-person visit using two-way audio-video. Prescription drugs orders can be issued during using telehealth services, and there are some parameters because obviously there's some medications that are not appropriate. And also it talked about support for multidisciplinary collaboration, having access through telemedicine to other specialty and increasing the access for patient care with the hopes of increasing continuity of care, especially on patient-centered medical homes. The New England Journal of Medicine did a really great article a couple of years ago where they talked about the different types of telehealth and telemedicine itself. You know, when we call our specialty colleagues, or when, you know, the primary care called the specialty, we're really doing clinician-to-clinician telehealth doing that when we put those non-visit electronic consults or curbsides. And the hope is that we can increase access to evidence-based medicine, and that we can decrease those disparities to rural, low-income, and even incarcerated individuals, and with the hopes of improving medical outcomes and in a way that is also cost-effective. Dr. Sen, who spearheaded the COVID-19ICU.com, came up with a really helpful infographic of potential health footprints of the pandemic. And now that we are limited with shelter in place, and we want to make sure that our patients are not getting exposed to COVID-19, this might have some later impacts in their care, like by not having non-COVID urgent issues done addressed at the moment. Later on, we might see the wave of those patients and our access go down. But telemedicine can help mitigate some of that and hopefully maintain our patients with chronic conditions not having to get dysregulated under control, and then later having to come to our clinics and having to deal with that. And in the hope also that we decrease burnout and we decrease the mental illness impact for our patient and ourselves. So let's prepare. Before you even start doing telehealth, you need to be ready. And there are several things that are required. It's always good to go to the pros. And the American Telemedicine Association has a quick start guide, and it has also several best practices that you can access, and it's free. You don't need a membership to get access to those. They even have a COVID-19 one, which is really helpful. The American Medical Association also has some quick guidelines that is very helpful, and many specialty societies have their own. Some of these trainings even provide CME credits, so you might also benefit from that, and often it's free. So the point on these slides is get some training. It's really easy. They're short, they're quick, and to the point. And just know that in addition to state law, it's important that you know that there are some healthcare system specific requirements. That it's important that you know what your healthcare systems require and what the rules are, and if they require specific training, and make sure that you are complying with that, in addition to the state law. Now the state law, particularly if you're providing care to patients that are in the border of the state, you need to make sure that you are complying to the state of where the patient is at. So if you need a state license in that other state, that might be something you might need to look into. Although getting a state license has become increasingly easy with COVID-19 in a lot of states. That website of cchpca.org provides, it's a nonprofit that puts all the telehealth related policies in a very easy way to look through. So if you want to look at those states and see what their health policy regarding telehealth is, that's an easy website to look it up. CMS has changed a lot of their requirements and have relaxed a lot of those since this COVID-19 has happened. And on the Health and Welfare website for Idaho, you can find what those changes are. So it's definitely easier to do it, but just keep in mind that it may not be, just be careful that sometimes we want to do the easy thing and not do the best thing for our patients. It might be easy to do something that's, so I'll talk a little more about that a little later, but just know that website is very helpful with what the changes are. And be aware that after the COVID-19 crisis is done, some of those might change back. So keeping your eye out for that is going to be important to protect yourself. In the state of Idaho, they require verbal consent for providing telehealth. Some healthcare systems specifically required a written consent, so make sure that you know what the requirement is, because and that you comply to your healthcare system and the state. Some healthcare system required you to put some sort of limitation of exam. And also make sure that when you have some sort of script where you can keep all of these things as you're talking to your patient and not miss any of these required components. When you offer the patient telemedicine, and ensure that you give them options, that they have the options to drive, to see a face-to-face provider, although it's discouraged because of COVID-19, but sometimes it's needed. But they do have the option, and it's not something that they are absolutely obligated to do. There are some risks and benefits, and that needs to be discussed. And when you're transmitting health-related data, make sure that they are doing it in a secure way. Instead of emailing you this information, it's best to use things like the patient portal for your healthcare system, or they can call your nurse in the clinic and tell them what the blood pressures are, or blood sugars, or whatever data that they're going to be sending is. Another important component for the preparation is an emergency plan. Whether you are providing telemedicine to a clinic, or if you're providing telemedicine to a patient's home, an emergency plan is something you absolutely need before you start. And it should be part of your script as you're getting ready to see the patient. Know where the patient's physical location is, and know what their telephone is. You always need to have some sort of backup technology, and the good old-fashioned telephone is a good, reliable one, in case your patient has a heart attack during the visit, or a seizure, or starts having something of concern that you need to send emergency services to where they are, and stay connected until the emergency services get there. So it's important that you have that emergency plan at hand. And then if you're doing the exam far away, make sure that you know what the emergency contact is. Most electronic health records already gather that information, but just make sure that you can confirm it with the patient. And it's important that before you embark into this, anything that's giving you concern or anxiety, that you're addressing it, so you can protect yourself and make sure that you are complying to the necessary parts of the visits. And also make sure that it's an appropriate visit. Sometimes you're gonna get consults or your patients that have a chief concern that's not appropriate for telemedicine, and that needs to be checked before the appointment is done. There's some considerations that we need to do. For example, there's different cultures, and that can also affect the visit. There are some cultures where everybody wants to be in the visit, and you have to make sure that the patient is okay with all the family members being present in the visit. They have to agree to it. And there are some cultures where they don't want anybody else but themselves. So, being flexible about that. If there's an interpreter required, making sure that that is set up on the workflow before you start the visit, so there's no surprises later on. It's always recommended that you do a trial run with your staff, just to make sure that you don't get problems later on, specifically with these special populations. Older adults might require you to talk slower, or even they might need to adjust their volume or use a headset. They might need to sit closer to the screen, and you might not be able to see them well while you're talking to them, but they might be able to see you and might feel more comfortable, and that might help the rapport. The chat box feature is really helpful. Particularly, I use it a lot when I have a change in plan that might be a complex plan, or if it's a new medication, so they know what the name of the medication written is. So most platforms have a chat box feature, so don't underuse it. You can also share your screen. I often share things from UpToDate, or sometimes images from New England Journal of Medicine physical exam. So again, another helpful part of a lot of the platforms. And then be aware that patients that live in remote rural areas, there are some small time disclosures, and then substance use needs to always be addressed, because as we know the statistics on this. All right. And then another important part of preparation is the equipment that you're going to use. What are you going to use? So a codec is, it's a term that is an all-in-one technology. The picture on the bottom is what a codec looks like, an example of a codec. It has an integrated camera, microphone. It encrypts and decrypts in the technology itself, and it can be used with several platforms. If you're going to do a lot of telehealth after a lot of telemedicine after all of this, certainly is worth investing. They're not cheap. They are around 1,000, 1,500, depending on which one you get. So, but if you're going to do a lot, it's definitely worth investing in. But you can also use a plug and play USB high definition camera like I'm using right now. With a microphone, sometimes a headset microphone is better because you get less echo effect. And then when it comes to your internet connection, wired connection is almost always better than Wi-Fi. And if you're teleworking from home, negotiate with your home teleworkers to perhaps not play a video game while you're doing a video visit, just so that you can have enough bandwidth for your visit. So that's something to always think ahead, that you might need to let them know when those visits are, and adjust. And then make sure you have proper lighting. Right now, I have a overhead light, and with the overhead light, you look dark like from halfway to your face down. With forward lighting, well, it looks pretty good. If you have backlighting, you're going to look completely dark. So you definitely want to be aware of that. Sometimes people use a vanity, one of those vanity mirrors that has lighting on them, or a small sat lamp, or even just a small flash for video cameras. They're not very expensive. Right now, this is me with it, and this is me without. So you can see the difference. All right, moving to the next one. So the workflow will be different, and at the beginning you might need to adjust, and your staff as well. So take time to think about what that workflow is going to look like with your team, and think about what a mock patient experience will be, and do a practice run. At the beginning, if you're going to see a lot of patients that are not used to the technology, also allow time for that, because they're going to need to adapt. They might have technical difficulties. You might have technical difficulties. Those are inevitable. So it's important that you are prepared for them, that you have your backup technology, and you can always finish the visit on telephone if needed. And then make sure, one thing that is helpful that you could do if your nursing staff can spare the time, to do the check-in via telephone or the video before you do your visit. This is helpful in several ways. It helps the patient frame their mind that they're going to go in through a telehealth visit, and also helps them troubleshoot before you start your own visit, so the nurse can help them with them. So that requires the nurse to also have training and know the technology as well. But if they do it over the telephone, they don't, but at least they can talk the patient through the steps. And yeah, and that is, and this is just an example. You can certainly change it to what your team dynamics is, but that's just to think about. The point of this is the workflow is going to change, and you might need to think about that before you even start the visit. This is an example of what equipment can look like. Having two monitors is helpful because you can have the video on one. If the platform gives you the choice for you to make the video smaller, you technically can have it all in one monitor. But if you have two monitors, you can have the video in one and the healthcare electronic, the EHR in another. Having the camera, I'll talk about how to position the camera in a moment. having speakers or having a headset that has a microphone integrated or have a standalone microphone. The standalone microphone Jabra is really cheap, and a lot of telehealth providers use them. But a lot of them are not that expensive. I do recommend that you will, if your workstation includes a laptop, make sure that you can elevate it enough, like put several books under it, and maybe have a standalone keyboard so you can put it further away from you. And I'll talk about why that is later. But I recognize that because a lot of the telemedicine changes that we're including in our clinic are new, what our equipment might be limited. So there are a lot of different platforms, and they toss the term HIPAA compliant, and that's just a fancy way to say that is encrypted. So it's either encrypted or it isn't. And just know that what is considered encrypted and a lot of the time is things like Skype Business, but not regular Skype. Zoom HIPAA, but not Zoom regular. Cisco technology, like Prexip and VA Video Connect is another one, but there's others like Securus is a telemedicine platform for prison care. So it's another one that is often used. Doxyme and Doximity are also well known, and VZ. But there's a lot of other ones. There's many. I don't endorse any. I just want to, the point of this to know is that there are many. And although there are a lot of relaxed rules about what HIPAA compliant, you should try your best to use a HIPAA compliant one, because like I said, sometimes it's easy to do the easy thing, but it might not be the best thing. So you also have to protect yourself. Again, and HHS relaxed their HIPAA platform compliance, but that's the website where it talks about specifically. And the caveat on this is, again, that it doesn't really explain how it's going to protect the providers, which I find a little, just be aware of that. All right, let's get to the good stuff. Let's talk about the skills. So just like we have bedside manners when we're providing care inpatient, when we're providing care via telemedicine, we need website manners, and we need to limit mannerisms, and that's professionally. I recommend avoiding clothes that are close to your skin color, because it might make you look like you're not wearing anything. Certain patterns in our clothes can be distracting to patients, so be aware of that. If you can wear clothes without patterns, that would be even better. Remove any items in the background. You want to still keep that boundary, so no family photos. And to the best of your ability, as I know it can be really hard, try not to have the kids come in, or the dogs, or the cats. Sometimes it can't be helped, but to the best of our ability, do our best to do that. Keeping a neutral background is helpful. It takes away any distraction that the patient might have. You can have a painting in the background, or those are fine. Just make sure that it's something that is not going to trigger a patient in any way. All right. And when we're talking to our patients, because a lot of these technologies are voiced over IP, sometimes they only allowed one person to talk at a time. So you don't want to talk over the patient. Give them time to finish their thoughts. Observe for those nonverbal cues, those behavioral cues that might let us know if they're following the conversation. Glance at the camera every 30 seconds. When we we're trained to do clinic and patient encounters, we're told to look at the patient's face every 30 seconds. Well, the same thing applies here, but with the camera. Keep a good attitude, because technical difficulties are inevitable. They are going to happen, no matter how great we are. So keeping a good attitude helps both us and the patient still trust that we're going to take good care of them. And then again, know what your backup technology is and have that conversation with the patient. If we have technical difficulties, I'm going to call you on the phone, so they know. And again, part of your script when you're getting ready, so you have it all set up and you don't miss a step. And then here's where we try to explain what the gaze angle is. So the gaze angle is, so you look like you're looking at the camera or patient's eyes. You have to make sure that that you have enough distance between the camera and yourself, and that the camera is raised. Um, another tip that you can also use is you can consider not typing midway or higher in your screen. That'll also keep your eyes looking closer to the camera. I know that's not a laser, that's just the line that goes to the camera. But that website explains very well the concept of gaze angle, and it gives excellent tips on how to do your home setup or your office setup. All right, I did skip one thing. Another technique that you can use is reflective typing. You know that when we have reflective listening, we are acknowledging that the patient told us some information and we're saying it back to them. So with reflective typing, sometimes if our time is very limited and we need to stay on time with our charting, sometimes we can, after the patient say their piece, we can say, what you're saying is important. Let me write that down and just call it. Just say that you're going to type it, and be transparent about it. When it comes to telehealth, the more transparent you are, the better the report with the patient is. So be like, what you're saying is important. Let me write that down, and they might even give you additional information as you're typing it. So it works out. So when it comes to video over telephone, the video visit is closer to a face-to-face. Obviously, it's not the same, but it's still better than a telephone visit. After a few minutes, the report is similar. And with a video visit, you can see who else is present in the room. Do they want those people there? You can also see their facial expressions and those behavioral cues, how are they taking news, whether they understand the information, especially if you're giving bad news. Is very helpful. You can also do a physical exam that requires a visual assessment or very limited maneuvers. The video is almost always going to be better technology if it is available. Another consideration is the workload for the video is more than the telephone. And the majority of, at least in my case, the majority of primary care is cognitive. So it is appropriate that we get equivalent credit for the time spent one-on-one with the patient. So for patients that are coming in for respiratory concerns that they might have COVID-19, observing how alert they appear, are they engaged, do they appear comfortable, are they speaking in full sentences, are they diaphoretic, are they having any word number dyspnea, are they using what are the visual cues that they are exhibiting with their mood, any nonverbal sign of pain that we might see. If they have a thermometer at home or a blood pressure cuff, they can also check their temperature, blood pressure. Some people even have a pulse oximetry fingertip at home. An exam that I like to use is the Roth score. The Roth score is a screening test for hypoxia. It can be used in the primary language of the patient. Can also be done over the phone as well. But in COVID-19, definitely on the young, healthy patient, it's an easy test to do. If patients have, COPD or heart failure and chronic shortness of breath, then that might be a little more complicated, but it's something to consider. And their reference is on the bottom there. So the big take-home point for the physical exam is that you will need to instruct the patient if they're using a mobile device or if they're using their computer camera. You need to instruct them on how far from the camera they need to be to get this physical exam, how they need to what kind of maneuver they need to do, or their caregiver. And then you have to also accept that there are some maneuvers that are just not possible through telemedicine, and that's just the reality. And then some require chaperone and also our own comfort level. So let's go to, this is an example. If you can use things like New England Journal of Medicine physical exam photographs or up-to-date photographs where you can show the patient what you need them to do, or you can do them yourself. Like, let's see what your range of motion on your shoulder is. Let's do this. It can be as easy as that, and so you can have some type of exam. To the very least, triage the problem. All right. Oh, I went too fast. Okay. This is an example of what the VA National Telehealth Primary Care Curriculum Group has been working on. These are some exams that we have been able to do in several sites with patients. One interesting thing about this is, again, some require chaperones. It's important that you have that. And then the comfort level of the provider. Some providers might not feel comfortable doing some of these. And again, you can look at this on the slides that will be available for download in detail. So with that, we cover preparation, equipment, skills, and some tips and tricks about physical exam. I will give the presentation back to Steve. And
very good. Thank you, Dr. Ambert-Pompey. That was great material. While people are sending in their questions via the chat function, and we'll get ready to field those, what I want to do is go now to Andrea Robertson. She is the clinic manager for the Idaho Nephrology Associates Group, and there she is right there. So I'm going to go ahead and unmute her. She was able to get her clinic up and running very quickly, and we'd love to have you share how you did that so successfully with your doctors. Andrea, go ahead.
So thanks, Steve. Dr. Ambert-Pompey, that was an excellent presentation, and I wish I would have had access to those slides prior to the time that we started, because what you described is basically what we did, but not with any kind of formal guidelines to follow. I think some of the things that you highlighted that played out well here was to practice with the staff as far as how to schedule the appointment, walking the patient through it step by step, because a lot of our patients are older and technology is a little bit of a challenge. And so to start that process, I practiced with the staff. We wrote out what the conversation would be, practiced different dialogues, had them act as patients with each other, logging into the system. We chose to use Doxy. And so that they became familiar with it prior to the time that we started scheduling patients. Once we started doing that, it was just taking that time to walk through it with them, to make sure they were comfortable, to encourage them to practice prior to the time to their appointment. And we treated it in the same way that a clinic visit would occur. The nurse called the patient, not via telehealth, just a phone call, prior to the time of the visit to prep the chart and prepare it for the doctor and then send it to the doctor. And at that time, then they confirmed that the patient was able to log in via telehealth and ask them if they had any questions or problems. And we also practiced with the physicians. A lot of the things that you were saying, having 2 different screens set up is very helpful. Using headphones is very helpful, so that there's not a lot of background noise. Also had them go home and try their bandwidth. One of the physicians here lives a little bit more remotely, and the bandwidth at home was not sufficient. And so we had to make alternative arrangements for that.
Very good, great contribution there. And according to Dr. Pintar, who's on our board, he said that he was quite impressed with your skills. So thanks for that. And I know that you're a resource for others. If anybody else would like to contribute about your experience, feel free to do that. Dr. Baruch would like to know how you chose a telehealth platform. Would anybody like to comment on that? I'm going to give you the opportunity to go ahead and unmute yourself at this point if you'd like to, or if you let me know, we can call on you. I'll start with Dr. Ambert-Pompey. How did you go about choosing your platform or your equipment? Is that something the VA required, or do you have any input into that?
Yeah, and in my case, the VA chose it for me. However, because I teach trainees and I want to give them a complete education, I do research on other platforms and what their differences are. CNET.com has a really great table that compares them that they just put. It's a good way to compare them in there. And I know with Zoom that they were in the news recently because of the problems that we're having. They engaged the lock the conference feature, which is new. They used to not have it. However, many platforms do have that feature precisely for that very problem that Zoom was known to have in the news. Another thing that I would say, apart from the platform, is offer it to every patient. Take your own personal bias out of what you offer the patient. Offer it to all comers, whether they are comfortable with technology or not. You don't really know that. I have a patient that's in his 90s and he used to be a communication tech back in the military. And he loves the fact that he was able to do telehealth now. So don't remove your own bias from when you're offering to the patients. And there are several programs that provide grants for loaner equipment. I know the VA has one, but there are some outside of the VA that do. So you can also look into that if you have special populations that might not have access to the equipment.
Steve, maybe I'll just jump in a little bit. As we've been scheduling so many patients with telehealth and they've gotten a lot of phone calls from their other providers, one of the things that I liked about Doxy and that the patients seem to like, not that I'm promoting Doxy, is that there's no additional download that's required. They can just go straight through the internet, either on their phone or on their computer. And that was a good feature for us.
Very good. And it looks like Scott Culpepper also mentioned that they use Doxy too. Very good. Anybody else want to jump in here if you're using telehealth, advantages or negatives on any of the platforms that you're using right now, things that you found to be useful, affordable, or otherwise?
Hi, Steve. Sarah Smith here. I work at St. Alphonsus in the geriatric and internal medicine office in Boise.
Great, go ahead.
Of course, we've had rapid conversion to trying to see our high-risk, vulnerable population remotely or via telemedicine platform. And initially, we used the VC application or platform, and now we're switching over to ClickSoft. I personally haven't had problems with either platform. I think our biggest hurdle is trying to get all of our patients comfortable with it. But I did learn recently that some home health agencies are offering to have home health nurses go into patients' homes and help with a tablet so that they could then interface with their providers. So that's an option that's coming. And I'm not sure which agencies are offering that currently, but I know that's something my clinic was looking into and something to keep in mind if we're struggling to get folks those services.
That's a great comment. I remember yesterday when Dr. Ambert-Pompey and I were talking, she said that the VA also does a similar thing of loaning out iPads as necessary. Just as our schools are having to loan out Chromebooks or whatever to students, we may find that that's necessary for those who don't have the technology or the money to do that. Super contribution there. Does anybody else have any experiences that they want to share as they've made this modification either recently or in the past? We'd love to hear from you at this point, or questions that you have for anybody on the call.
Speaking more to the loaner program in the VA, patients that I see that are in the end of life, caregivers love the loaner tablet. They feel like they're being supported very well with it. And after the patient passes away, they feel like it really helped. So just putting that out there.
That's good to know. Very good. Well, unless anybody else wants to raise their hand or jump in here now, I'm going to go ahead and share my screen again and remind you that we do have next week, the Idaho Medical Association will be hosting the Changes and Challenges Education Series, which is every month, 12/15. You do have to be a member of the IMA, and you can register at idmed.org. They'll cover all of the things that we didn't cover today. Pam Fisher, our specialist at the IMA, reimbursement specialist, will be speaking about that. Also, that very morning from 8 to 9 a.m., Ada County Medical Society, the IMA, and ACMEC will be co-hosting the St. Luke's Grand Rounds. Dr. David Pate, we expect Dr. Sky Blue, and Susie Pouliot, the CEO of the IMA, will be there to kind of provide a behind-the-scenes look at what else is going on in that realm. Dr. Pate sits on the Idaho Coronavirus Committee, and so he's been willing to step forward and share. Dr. Sky Blue and he were on Idaho Matters on KBSX yesterday. And so we expect to be able to have Dr. Blue there to talk more about the COVID testing and antibodies testing, as well as other matters that you might have. Since he's an infectious disease specialist, he will be there, hopefully will be there and be available for us. Thanks for joining us today. Thank you, Dr. Ambert-Pompey, for your contributions today. It was excellent.
Thank you.
All right, everybody enjoy your day. We appreciate you. Keep yourself safe. Please take care of yourself. Access the Physician Vitality Program if you haven't had a chance and you need to. Have a good day.